Hi everyone, in the series of Head and Neck Anatomy, in this video we are going to look at eye and orbit. I am Sabir, third year medical student, University of Jaffna. We are going to emphasize important concepts that need to be understood and some important details, not every minute detail. In this video we are going to look at bony orbit, lacrimal apparatus, eyelid, extraocular muscles and eyeball anatomy very briefly. Moving on to the bony orbit. It's a bony cavity in front of the skull, pretty much a four-sided pyramid in structure. So it has an apex. It is more or less the optical canal through which mainly the optic nerve enters into the orbit. It also has a base, which is the orbital margin, which formed by the respective bones which form the orbit. So, if we take the organization of two orbits, here we can clearly see that their medial walls are parallel to each other, unlike their lateral walls. The orbit is formed by these 7 bones: frontal, zygomatic, maxilla, lacrimal, sphenoid, ethmoid and palatine. So, here we have to understand the walls precisely. So, we are going to do a simple thing. We are going to unwrap the pyramid. So, the structure look like this. These 4 triangles represent 4 walls. Here, the medial wall is formed by ethmoid, lacrimal, frontal bones, and the roof is formed by lesser wing of the sphenoid bone precisely and the orbital part of the frontal bone. When we are talking about the lateral wall, it is formed by the frontal process of zygomatic bone and the greater wing of the sphenoid bone. When we are going to talk about the floor, it's formed mainly by the maxillary bone and the palatine bone, a part of small e, and the same bone, zygomatic bone. So here we can see that the apex is more or less the optical canal, but it is in the lesser wing of the sphenoid bone. And we also have other two major openings. Here we see two oblique slits or fissures. The upper one is a superior, the lower one is a inferior. So there are superior orbital fissure, inferior orbital fissure. These are the main pathways through which the structures enters or goes out into the orbit. Comes like the inferior orbital fissure is between the zygomatic bone and greatest wing of the sphenoid bone. Is it true or false? It's false because it is between the greater wing of the sphenoid bone and maxillary bone. Here in the optic canal, the optic nerve and the ophthalmic artery goes through. In the inferior orbital fissure, the infraorbital nerve and the zygomatic nerve goes through. In the superior orbital fissure, there are many nervi and the vessel structures goes through. So, to keep that in mind, we are going to use a mnemonic only for the nerve structures. So, live frankly to see absolute no insult. Here the first letter suggests the nerve. So here the oval shape represents the tendinous ring, the common tendinous ring, from which most of the extraocular muscles arise, except levator palpebrae superioris and the superior oblique. So now you can see that there are 4 nervous structures from the oblique fissure, oblique orbital fissures, and the optic canal goes through. Here, the optic nerve, ophthalmic artery, the oculomotor nerve, the nasociliary nerve, the abducens nerve, the oculomotor nerve goes through the tendinous ring. Other structures go out of this tendinous ring. So it is a commonly asked question that which are the structures that goes through the common tendinous ring. Medial and flow are relatively weaker than other walls. So if a blunt blow is applied, there is a high chances of these walls getting fractured. So what happens? The content of the orbit herniate through these fractures. So the extraorbital fat will herniate through the fractured flow into the maxillary sinus. Also, if the flow is fractured, the infraorbital nerve will also be fractured because it grooves the infraorbital nerve which supplies the lower eyelid. Moving on to the lacrimal apparatus. Its functions are production of tears and removal of excess tears. It has two components, gland and passage. The passage contain punctum, canaliculi, lacrimal sac, nasolacrimal duct. Moving on to the gland contain large orbital and a small palpebral part. The large orbital part is located in the lacrimal fossa, in the lateral part of the roof of the orbit. The palpebral part is visible through the superior fornix of conjunctiva. From the palpebral part, there are 12 to 15 lacrimal ducts drain into the lateral extent of the superior fornix. The closure of the eyelid begins at the lateral side of the upper eyelid and moves medially so the tear can be spread. In normal condition, the production of the tears is just to replace the evaporated tears. At the end of each eyelid margin, medially, there is a low elevation called lacrimal papillae. It has a minute two holes called punctum. From those two holes, the superior and the inferior canaliculi drain into the lacrimal sac, or the two canaliculi form a common canaliculi and then drain into the lacrimal sac. The lacrimal sac is in the lacrimal groove formed by the maxilla and the lacrimal bone. Some deeper fibers of orbicularis oculi attach to the lacrimal sac. When the palpebral and the attached deeper parts of the orbicularis oculi contracts, the lid close. So the puncta close inwards and dipped in the lacus lacrimalis. At the same time, the lacrimal sac opened widely. So the tear is drained through the canaliculus into the lacrimal sac and goes into the nasolacrimal duct. The nasolacrimal duct is 2 cm in length and goes downwards and backwards. The nasolacrimal duct drains into the nasal cavity through inferior meatus, and in that junction the wall contains serous fold that acts as a valve, so the reflux of tears into the nasolacrimal duct is prevented. The lacrimal sac and the nasolacrimal duct are covered by ciliated columnar epithelium, epiphora. It's a condition in that tears runs into the cheek. It may be due to excess production of tears or may be due to the obstruction of the drainage system of tears. Eyelid, as we already discussed, it helps to distribute the tears and protect eye. It is covered in front by skin and loose connective tissue, behind adherent to conjunctiva. Their fibrous framework is orbital septum. They thicken at margin as tarsal plate. Eyelids meet in medial and lateral angles called canthus. The lateral angle, the lateral canthus, is in direct contact with the eyeball. The medial, separated by the triangular lacus lacrimalis, and there is a small pink elevation called cranuncle. And also there is a semilunar concentric fold lies lateral to this. The tarsal plate is a dense connective tissue. Medial palpebral ligament anchors into the lacrimal crust. Lateral palpebral ligament anchors into the zygomatic bone. This is the cross section of upper eyelid. These are the layers. Skin and subcutaneous tissue, the palpebral part of orbicularis oculi and levator palpebrae superioris muscles, the orbital septum, the tarsal plate, the conjunctiva. The tarsal glands are modified sebaceous glands that are embedded in the tarsal plate. They delay the evaporation of the tears and prevent the spilling of the tears. There are also sweat glands open into the eyelid margin between hair follicles. Holodium is a state where these glands are infected. The upper eyelid possesses more mobility than the lower eyelid. Lids are closed gently by the palpebral part of the orbicularis oculi, forcefully by the orbital part of the orbicularis oculi, which is supplied by the seventh cranial nerve, facial nerve. Eyelids are opened in ordinary way by the levator palpebrae superioris, which is supplied by the third cranial nerve, oculomotor nerve. So, here the seventh nerve closes the eyelid and the third nerve opens the eyelid. Conjunctiva is a transparent membrane. It has three parts: palpebral conjunctiva, superior conjunctival fornix, bulbar conjunctiva. The palpebral conjunctiva rich in blood supply, so it's usually red color. In anemic condition, it will turn to pale color. It is the clinical indicator of the anemia. The extraocular muscles. These are the axes of the eyeball movement. Medial and lateral rotation is possible through vertical axis. Elevation and depression is possible through horizontal axis. Intorsion and extorsion is possible through anterior-posterior axis. If we look at the orbit in the superior view, this is the axis of the eyeball and this is the axis of the orbit, and this will be the common tendinous ring and this will be the superior rectus muscle. By looking at this picture, now we can understand clearly that pure elevation is not possible despite of its name suggests that. Then the need of the oblique muscles come into play. These are the overall attachment of the extraocular muscles. Here, the superior oblique comes superiorly and medially and goes through the trochlea, which is near the orbital margin, and again come backwards and downwards and attach to the eyeball. Other than the actions of the medial rectus and lateral rectus are quite complicated. So, we are going to simplify things. By looking at this simplified diagram, we can say lateral rectus and medial rectus produce simple movements such as abduction and adduction respectively. When we look at the inferior oblique, it produces abduction and elevation and extorsion. As like superior rectus produce elevation and adduction and intorsion. So to produce a pure elevation, inferior oblique and superior rectus must contract coordinatingly. As we again looking at the depression, to make the pure depression, the superior oblique and the inferior rectus contract coordinatingly. Binocular vision is depend on properly coordinated six muscles of each eye. So, if the muscles are not coordinated, the image not fall on the corresponding point of the retina. So, the double vision, the diplopia will be resulted. The nerve supply of extraocular muscles. The mnemonic LR6SO4 means LR6 means lateral rectus is supplied by the sixth cranial nerve, the abducens nerve. and the superior oblique is supplied by the fourth cranial nerve, the trochlear nerve. The other remaining extraocular muscles are supplied by the oculomotor nerve, the third cranial nerve. When complete nerve lesion happens, it produces strabismus and diplopia. In abducent nerve lesion, it is difficult to look outward, and when trying to look forward, the affected eyeball is pulled medially because of the unopposed action of the other muscles. In the trochlear nerve lesion, cannot look downward as it before because of the superior oblique paralysis. So the patient will complain diplopia during reading and difficulty in going downstairs. Also there is some extension. So to compensate the extension, the patient tilts the head towards the opposite shoulder. In the oculomotor nerve lesion, most of the obvious feature is ptosis of the upper eyelid. When looking forward, the eyeballs goes downwards and outwards because of the unopposed actions of other muscles. But when looking outwards, diplopia will not be resulted because of the sixth nerve abducer nerve is intact. The pupil will not constrict because of the oculomotor nerve lesion, but the consensual right reflex replace this and compensate it. Lastly, we are going to look at eyeball very briefly. That's all from this video. Hope you enjoy. Thank you.